Dr. Sharma, can you see the slideshow?
Yes, yeah. So introduced, we can move on to the next. So our learning objectives, I hope by the end of the lessons, we would be understanding what is the hallmark features of Parkinson's disease, what is the basic pathophysiology of Parkinson's, and be able to recognize the early symptoms of Parkinson's and be able to understand the common treatment and, most important, the preventive modalities for Parkinson's disease. So I kept these questions so that we can keep everyone engaged and awake during this presentation, which can sometimes become a little dry. So what is the current understanding? What is your understanding of Parkinson's? Anyone who wants to just say one or two lines, then we can go further on that. That would be great. So anyone who can unmute and just say what they understand by Parkinson's or what they're interested in.
Losing control over our movements, voluntary control.
That's right.
My neighbor has this problem. Always her hands are trembling.
That's
so,
right.
Yeah. Anything, if she takes out, just they are trembling like this. So I think it was Parkinson's disease. She is taking some medicine, but no effect just in India.
Okay. Yes, those are very two common common features of Parkinson's. Anyone else? Thoughts, questions before we start?
I think the way I understand is Parkinson's is also related to some changes in the brain chemistry, which the connection between the brain and the muscles movement connected with that control over the muscle movements.
That is right. I think you all have nailed down three very important parts of this. Okay, we can move on. So how common is Parkinson's disease? So in America, about 1 million Americans are affected, approximately 0.3% of the general population. But when we just do the geriatric population, or I would just say over 60, it's hard to say what's geriatrics now, but over 60, 1% of the population have Parkinson's disease. So it is a big number. And what is the average onset age? It's come to 62 years. Now, very often it's older than that. So we see people in 70s and 80s, 85s have it, but average age is 62. And unfortunately, sometimes very young, 40s can also have Parkinson's disease. The incidence increases with older age. So as the general populations are getting aged, in nursing homes, it's very common to see Parkinson's disease in 85, 90-year-olds. And it has got a slightly higher prevalence in men in comparison to women. So we have a nice video which goes over the symptoms of Parkinson's disease, which will go over some of the symptoms you all talked about. So we can play this video. It's a 5-minute video, so we can play that.
So Sadie's kindly agreed to be involved. I'm going to examine her walk, and as you'll see, this is when she's off treatment compared to when she's on treatment. So when she's off treatment, Sadie has Parkinson's disease. So the salient features will be evident when she walks towards us. So Sadie, in your own time, can you walk towards us? And as you can see, she's got quite a flexed posture, mild hypomimia or expressionless face. And there's a reduction in the arm swing, particularly on the right, but on both sides, really. That's great. And if you could turn around and walk away from us again. Turns tend to take a number of steps more than is usually required. And the stride length is quite low. She doesn't actually have a tremor at the moment, so she's partially treated. And then turn around again, 2 extra steps to turn. And then come on back, thanks. And the reduction in arm swing is the key thing in early Parkinson's. That's great. Thanks. You can just stand there for a moment. Can you hold my hand? And there are no limitations elsewhere. So if you could walk up onto your toes. Fabulous. And down again. And onto your heels. I've got you. Great. Okay. That's fine. And I'm just going to examine. You can put your feet apart a little so you don't become too vulnerable. And you're looking for lead pipe rigidity at the elbow and cogwheel rigidity at the wrist. And Parkinson's, idiopathic Parkinson's, when it starts, is usually asymmetrical at onset. And in Sadie's case, it's more marked on the left-hand side. So I'm going to move your left-hand side, if you don't mind. So at times it can be nice and free, looking for lead pipe and cogwheel. And then you perform, to exaggerate it, the Kinnear-Wilson maneuver. So if you don't mind, Sadie, if you can just lift your hand up and down, gently now, while I do this. And I should be able to bring out a little bit more lead pipe, a bit stiff at the elbow. And you can see that it's certainly much more stiff at the wrist, which is the cogwheel, which is supposed to be the lead pipe, which in the elbow superimposed the tremor that Sadie sometimes has and sometimes does not. That's great. Thank you very much. Have you noticed any change in your voice since you were diagnosed?
Yeah, it's probably gone a bit lower.
So that's hypophonia. So the pitch or the loudness of the voice goes down a bit. But swallowing is okay and everything, is it?
Yes. Provided I drink when I eat, I mean, I can't swallow. It's very dry.
And have you ever had any falls due to this?
I mean,
Falls.
oh no.
Well, it's one of the important red flag signs when you're trying to distinguish between Parkinson's and Parkinson's plus syndromes. You ask about autonomic features such as bladder problems, bowel problems, and swallowing problems, and also recurrent falls might be a red flag for Parkinson's plus syndromes such as multisystem atrophy, progressive supranuclear palsy, cortical basal degeneration, etc. But when you take Cinemet, isn't it, which is a mixture of L-DOPA and a peripheral decarboxylase inhibitor called carbidopa, when you take that, how long does it take to work, in your view?
Well, it's Stalevo, you mean?
Stalevo, sorry, which is adding in entacapone.
Maybe after 10, 15 minutes.
Okay, and after 10 minutes, it starts to work and you feel what?
Well, I feel myself getting freer.
Freer.
Yes, and the symptoms was, the feelings, the numbness and the tingling feelings, which is,
Yes. It's actually described as numbness and tingling, but in fact, it's an inner sense of trembling, isn't it?
Yeah, very much so,
even though you can't see it. Okay. And then it works for how long before it starts to fade off again?
3-4 hours.
3 to 4 hours. And will you know it's wearing off?
Yeah.
And so the point is, when you're taking a history from someone with Parkinson's or Parkinsonism, is you want to know what time they take their first tablet, how long it works, how long it takes to work, how long it works for, and when it wears off. And then when they take the next one, of course. And then the other crucial thing is, do you or do you not get, when you're taking the medication, abnormal movements where you get, you don't get any. So they're called dyskinesia, when someone is getting too much L-DOPA or they're having a reaction to L-DOPA. So you can get dyskinesia at the top of the dose, peak dose dyskinesia, or at the end of the dose, wearing off. And you need to know where in the cycle, if you like, of on-offism in Parkinson's, where the dyskinesias come in, because that's then where you pharmacologically act, so to speak, to try and alleviate symptoms. Okay. Thank you very much indeed. That's great. Thanks.
All right. So this gave us, I hope, gave us a good sense of, we can go to the next slide and we can just stop here and discuss a little more of what we saw. So we saw these symptoms. Now, this patient did not have much tremors. So we'll talk about, I think Nalini ji brought about tremors. We'll talk about tremors in a bit. So every person with Parkinson's disease may not have everything. They may just have some of the features, at least in the beginning. So these are the 4 common features. Bradykinesia, which means everything becomes a little smaller. So you saw this patient walking very small steps. You saw her speaking very softly. The expressions of the face had become lesser. The blink was reduced, the facial expressions, the gesturing, the voice was softer, the steps were a little shuffling. She had a smaller step. She didn't have the typical shuffling where you can hear them. They drag the feet and you can hear them moving their feet very slowly. The arm swing gets lesser, so when they're walking, their hands don't move as much. Sometimes they stop walking suddenly, and we call that freezing. The tremor, there are different kinds of tremors. So when the neurologist or the doctor is checking, they will look at what kind of tremor does that person have. Is it happening only when the arms are out? Or is it happening when the arms are at rest on their lap? And in Parkinson's, it's usually seen at rest. So when their hands, so usually we'll say, put your hands on the lap, and you see the hands doing this kind of tremor. So the thumb and the index finger are going this way, and we call that pill rolling tremor. And pill rolling is because in old days, the pharmacists used to make the pills in this way. So that's how it's called pill rolling tremor, in which the thumb is moving. So that's the typical feature of Parkinson's, but not everyone may have that, or they may have it a little bit later. The next one is the postural change, which is a very important feature of Parkinson's. So postural changes is they are not very steady on their feet. They have that imbalance, they can have falls, they can have the stooped, flexed posture, which you saw in the video. And then lastly is the rigidity. Rigidity means when you check the arm or the leg, the nice smooth movements that we all have is not there, and it becomes a little tighter. And there are different names of the rigidity based on when that tightness happens. If the tightness is happening all along, we call it lead pipe. It's like a lead pipe. And when it happens slowly and jerkily, we call it cogwheeling. So you'll see the doctor checking the wrist and checking the arms and checking the legs to see what kind of rigidity there is. So in Parkinson's, you can think of that smoothness that is there. So you can think of a well-oiled machine. The well-oiled machine moves smoothly. But when that oil is lesser, then it becomes stiffer, it doesn't move as well. That's how you can think of Parkinson's disease, that oil that is needed in our body, which we will talk about in the next slide, what that oil is lesser. As a result, you have these 4 predominant features. We used to have a mnemonic calling ART, A for akinesia and bradykinesia, R for rigidity, T for tremors, and finally postural instability, PI. So that's how we remember the common features of Parkinson's disease. Anyone who wants to talk about these right now, or can ask any question about these symptoms at this time?
You can raise your hand or just unmute yourself and introduce yourself if you have a question. Anyone from the video? Any questions on the video?
Hello. Can you tell us the symptoms at early age? What you said it's around 60 or it's onsets, but do you see any symptoms prior to that? What kind of a symptom is going to be? Forgetfulness, anything of that kind?
Usually the cognitive part is a little bit later. So we can talk about that as we go. What are the other features that we see? Parkinson's predominantly starts with the motor part, and the motor part of the slowing of the movements, the tremors, the postural instability are the usual ones. It's very, very subtle. People will say that sometimes they get the tremor and then it goes away. It could be one. Sometimes they feel imbalanced, and it's a very slow progression. So the next slides will tell us how slow the progression is. So the symptoms, as you said, it could be subtle. Usually in about 2 to 3 years, it starts showing up more.
Dr. Sharma, in the video, there is that the doctor asked that there are tremors. Is the patient feeling inside tremors or the tremors that we are looking outside?
So they're both. When she said that she feels, when she takes the medicine, she feels as if the tingling and numbness is lesser. But the doctor explains that it's not actually tingling and numbness, it's more that inner sense of tremulousness. So there is an inner sense of tremulousness. And patients don't sometimes know. So they'll come and say they feel dizzy, or they feel imbalanced. And when you see them, you don't see it, but there is an internal sense of imbalance. That is correct.
So you think, is it correct to say that it starts internally for a diagnostic purpose, for somebody to say, I don't feel right, to go and check with the doctor, or the external are better, like for
So
that?
it could be either. Sometimes patients can present just with external tremors, and they come with that. And sometimes they will come with the sense of feeling unsteady when they're walking, or feeling a sense of tremulousness inside them. So it could be anything.
Can be either. So one more is did he say that when you are taking the medicine, there is dyskinesia on the peak or wearing off? Is that a term where there is abnormality in the tremors, or?
So dyskinesia is a terminology we use for the abnormal movements which happen due to medication.
Okay, so that is what I'm thinking. So they are taking, but you have to watch out for something which is different from regular, even when taking medicine. That is one of the effects, side effects.
Correct, the side effects. So we have to adjust the medicine, what time to take the medicine, how much to give. Those adjustments have to be made if we see the dyskinesia.
Sounds good.
Hari Om, my name is Vijay. 2 questions. One, is there any correlation between restless leg syndrome and Parkinson's? And if there is a RLS an early sign of possible coming up with a PD?
No. So restless leg is a very common condition. And most people with restless leg syndrome will not go into Parkinson's disease. But patients with Parkinson's disease can have restless leg syndrome.
Thank you.
That is good to know, I think, because a lot of us have this sometime or the other, restless leg syndrome, I think.
Thank you, Sujata ji. Thank you. I'm one of them. And second question, the video was very informative. Thank you for sharing it. Is there a possibility we could get the link to that video to watch it again?
Yes, I will give it to you. I will send it. I'll put it in the groups, and wherever you got the Zoom link, that would be the best one to get this link again. If not, please text anybody in Chinmaya Mission, and you will be getting it. I will make sure everyone gets it.
Thank you.
Okay, Dr. Sharma, I'm going to the next slide now.
Yeah, thank you. So this is the non-motor symptoms of Parkinson's. Some of you asked this question. So Parkinson's affects different parts of the nervous system, different parts of the brain. Earliest involvement is actually in the gut and the olfactory bulb. So the non-motor symptoms present as loss of smell. That's the olfactory bulb right behind the nose. There is part of the brain, which is the olfactory bulb. The degeneration starts in that. So the loss of smell is an important feature early on. The second is the other non-motor symptoms are the constipation. That's because there's a degeneration in the neurons inside the gut. The whole gut has a whole nervous system also, the parasympathetic nervous system, sympathetic nervous system, and those degeneration of that cause of constipation. Dry skin is another one, is often an early feature of Parkinson's disease. They have something called seborrhea there. The skin starts flaking and drying out, and that's also one of the non-motor symptoms of Parkinson's. Dream enactment is an important one. So dream enactment is not restless leg syndrome. It's suddenly in the middle of the night, they wake up and they can start screaming, shouting, walking. That is also one of the early features of both Parkinson's and also certain type of dementias. Can also cause mood changes, depression, anxiety, apathy, mania, and memory changes. So Memory changes can happen early, but majority of the time in Parkinson's disease, it's a later phenomena. The cognitive part is a little later in the clinical presentation. And then sensory symptoms are the pain, the sensation of discomfort, they call pain. The actual pain, like we experience pain, is not there in Parkinson's. And a sense of restlessness. That's what that patient in the video was also explaining. So these are the common non-motor symptoms of Parkinson's disease. Any thoughts, questions on this?
Parkinson can be the reason for some psychological experiences or some mental bad experiences. Because of that, Parkinson can appear. Means mentally, if the person has got some bad experiences, it can show in the Parkinson.
Not typically. So any time in any major trauma can cause your overall increased susceptibility to different illnesses.
Because
But
depression and anxiety, actually they come after Parkinson, or they are there and then it starts Parkinson.
So I would say that first, it is because of the onset of Parkinson's that the depression is manifested. However, there's another different condition is in patients with psychiatric condition, they are given certain medications which can present as Parkinson's disease. We'll talk about that also in future, in the next slide.
Excuse me, Hariom. The same way, the dry skin would appear after the onset of PD, or if the dry skin is there now, can that be a sign of oncoming PD?
So dry skin is a very common condition. To say that a dry skin is early sign of Parkinson's, I would say no. That would be unusual but there is a very typical type of dry skin in Parkinson's disease. However, if you say that early dry skin is going to mean that somebody may have Parkinson's, the answer would be no.
But maybe a good idea to get it checked, do you think? Not a general dry skin, but if you have patches or things like that, do you think it's a good idea?
You can definitely address it to your primary doctor. You don't have to go to a neurologist, but the primary doctor should be able to screen and say, okay, there's something more than just the dry skin.
Right, because I think that's interesting to know there is a connection to, I think, I mean, most of us have not heard, I think, so it's good. Just like constipation and loss of smell. I've not heard of it at all.
All right, we can go to the next. So this one has a nice little picture which goes over all the things we saw on this slide. So if you start from the faces, the expressions are lesser. We call it masked face. The posture is slightly flexed forward. That is the stoop posture. The back is rigid, so you don't see the fluid movements of the whole body because it's stiff. The elbows don't move as much and they stay a little bit flexed, meaning bent a little. The trunk is a little forward. So we say the center of gravity has moved a little forward in Parkinson's. The hands have this tremor. They're showing the pill rolling tremor. The hip and the knees are also slightly flexed. And there is sometimes you can see tremor in the leg. It's not very common, but sometimes you can see tremor in the legs when they're sitting. And the steps are short, shuffling type of. So you can, as I said, they drag the feet and you can hear them walking with sliding their feet. Getting in and out of the chairs and turning in bed becomes slower. So that's another way you can recognize the Parkinson's. You can go to the next.
What is masked face?
So masked face means the expressions are lesser. Like your face you can think of wearing a mud mask. When you wear a mud mask on your face, your expressions are reduced, right? Everything gets stiffer. So the name that is given to reduced expression is masked face. So now, what is the cause of Parkinson's?
Dr. Sharma, one question I have on
Sure.
that.
Yeah.
Masked face is like we are looking, right? We can see, I mean, doctors can see that. Do the patient knows that they're presenting themselves like that?
Usually not.
Hmm.
So they don't come saying that my expressions are lesser.
Hmm.
Some people might say that when I look at my pictures, it looks different.
Right, they can recognize that, I'm thinking.
Yeah, sometimes we'll say, can you show me your old pictures? Usually driver's license is what's available, right? So show me a driver's license 5 years before and now. And that way you can compare and you can see a change in expression. So sometimes if patients can, or the family members can more often. Good question. So what is the cause of Parkinson's disease? So the number one cause is idiopathic. What idiopathic means is we really don't know what is the cause of Parkinson's. Why do some people get it? It is really what we call a degenerative disease. That means as we age, all of us lose some neurons. But when some lose, we could say that there is a cutoff. We believe that we need only 30% of those neurons in that area. And when they fall below that 30% threshold, that's how a number has come. But what you can say is if for threshold, we don't need 100% cells. Say we need about 50%. And if you fall below that, that's when the symptoms start. So and as we age, we all lose neurons. The question is, how much do we lose and who gets a bigger degeneration? So that's idiopathic, is we don't know the cause, but there's a loss of the cells, which we call dopaminergic producing cells. So one of you had said that there's some chemical which is lesser in the brain, and that's what it is. So the chemical which is reduced is dopamine. And the cells which are producing the dopamine are the ones which are degenerated. And they are in different parts of the brain. So this has a nice little picture. And in that you see the blue area, which is around that is the part of the brain which we call the basal ganglion. So it's not on the surface of the brain. So majority of that walnut appearance is where all the cortical functions is, all the memory center, the speech center, all of that. But further down where that blue egg-like appearance is, and surrounding that area is the basal ganglion, which has different names. We don't need to go into the details of that. And there's one part which is called substantia nigra, which is producing these dopamine. So all this blue area that you see is the basal ganglion. These dopaminergic cells are responsible for the coordination of fine motor movement. So that well-oiled machine that I was talking about, that oil is coming from, which is lubricating our movements, making these smooth movements, is coming from dopamine. And when those dopamine cells, producing cells, are slowing down, degenerating, that's when the dopamine becomes lesser. So that is the commonest cause of Parkinson's. But there are some other causes which we brought on. Some are drug-induced. So there's certain medications which are used as antipsychotics in psychiatry patients, in dementia patients. We use medications to reduce their agitation, their psychiatric symptoms. And those antipsychotics can actually cause symptoms of Parkinson's. We actually call it secondary Parkinson's, not primary Parkinson's, because it's caused by something else. And then certain infections like post-viral encephalitis can cause damage to that area, the basal ganglion area, and then that can produce Parkinson's. And then structural lesions, if there is a stroke in that area, or if there is a tumor in that area, it can again present as Parkinson's disease. Any thoughts on that?
Is there a hereditary factor involved in the developing Parkinson's?
So there is a hereditary, it's a smaller percentage. It's not very strong component. And it's often seen in the younger group. So the people who present early onset, they are more, the hereditary factor is slightly more. In the older population, it's less of a component.
So Dr. Sharma, the hereditary factor, so it has been identified, the DNA?
Yeah, there are studies saying there is a small component of a hereditary factor, that families have it. It's not a very strong component.
Dr. Sharma, you mentioned about the dopamine generating cells. Dopamine, I understand, is affecting sleep also. In my case, for quite some time now, for a few years, I've been having difficulty sleeping at night, and it's getting worse and worse to the point of getting only maybe a couple of hours of sleep sometime. Tried several medicines, and any medicine benefits only for 2 to 3 weeks, and then it stops. And tried melatonin on the side. That kind of helped more than the medicines. Any thought on that?
So sleep is got a lot of different, what we call these chemicals, we call neurotransmitters. So there are a lot of different neurotransmitters which are impacted in sleep. Dopamine is but a smaller component. There is all other serotonin, acetylcholine, norepinephrine, a lot of different neurotransmitters which are impacting sleep. So your question about what to do, so there's a whole science of, without medicine, we call it behavioral sleep hygiene, a whole big topic of that. The melatonin is a safe way of taking it. It's one of the safest ones because the majority of the medications we have now for sleep cause long-term problems, and they become less and less effective. So seeing somebody who does sleep medicine, and also now there's a whole new cognitive behavioral therapy for insomnia, that is a good modality to try. So you can look online. There are some things about CBTI, cognitive behavioral therapy for insomnia. You can ask your doctor if he can send you to a sleep specialist. They can also give you advices. And when we talk in the end about sleep hygiene, I'll talk a little more about what is a good strategy for effective sleep.
Thank you.
Is lack of sleep or not being able to sleep a symptom for us in Parkinson's, or no? Because it is related to dopamine again.
It is. So sleep is in both ways. In the onset, so lack of sleep increases your degeneration of cells, neurons, and other cells as well. And Parkinson's itself impacts sleep. So it's two-way.
And Doctor, one question on the first bullet. Is there any test or something regularly we can do to detect that first bullet, the cause?
The idiopathic, you mean? No, the tests, you yourself being active and being able to do your usual activity is your test as well as the treatment. When you see yourself not being able to do things significantly different, even though you are doing everything, that is the early sign.
Thank you.
Good questions. Thank you. So here is a typical progression and the clinical course. So as you see, before the onset, for 2 to 6 years is what we call preclinical phase. it may not show up as anything. They might just think that they're slowing down because they're older. So it takes a bit of time before it actually presents. And then 0 is when they are actually diagnosed. The symptoms are there and the diagnosis is made. And then there's a honeymoon period. So for 3, 4, 5 years, it's very subtle. People may not know it. They may take medicine or very little medicine or no medicine. And then by 8 years, it starts getting more significant, more apparent. And then medications are still helping, but after, say, 9, 10 years, the medications are less effective. It becomes more resistant. And then after 15 years or so, in the majority of the Parkinson's, is when the cognitive decline happens. So as we were saying, the dementia part is a later phenomenon in Parkinson's disease, whereas in Alzheimer's, the dementia part is early on. So as you see, it takes a long time. So when somebody gets a diagnosis of Parkinson's at age, say 80, for them, it's like, oh my God, I won't be able to walk in a year or two. But if you see the pattern, it'll take them 10, 15 years. They're going to be 90, 95. So it might be till their very end of life, right? So it's not such a huge diagnosis when, or as devastating a diagnosis when somebody gets it at, say, age 80, 85. But if somebody gets it at the age of 50, 60, then yes, it could impact their later lives. So this gives it, go ahead.
Dr. Sharma, you have given us a great gift today by giving us this knowledge, information. Is it also possible someday when you have time to educate us on dementia?
Yeah, we can do that. Yes, definitely.
Yes, in my mind, I'm like, yes, we need more, I'm thinking, but we will discuss that later on, I think, right? Okay, anybody, any questions on this chart?
So question 2. So this time I'm going to see how much attention did you all pay, right? So what is the pathophysiology behind Parkinson's disease? Is it lack of neuron migration during early childhood development? Is it loss of dopaminergic producing neurons in the basal ganglia? Is it excessive activation of the neurons in the cerebellum, or is it loss of serotonin producing cells in the brainstem?
All of them?
I think it's B.
B.
That's correct. It is B. So we can move on to the next slide. It is the loss of dopaminergic producing neurons in the basal ganglia. The other ones are different other conditions of the brain. So we don't need to go on this right now, but that is it, the dopamine. So you all were paying attention. Thank you. And question 3, which of the following is not a manifestation of Parkinson's disease? Reduced arm swing with gait, hypophonia, which means soft voice, bradykinesia, which means slow, small movements, or a wide-based gait?
D like dog.
D.
That's
D.
right.
Wide-based gait.
That is right again. So that was, if you go to the next slide, wide-based gait. It is seen in other conditions, like in cerebellar conditions, or somebody with neuropathy sometimes have this wide-based gait. So you all were paying excellent attention, and we all got the features of the Parkinson's disease and symptoms. We can go to the next one. So this is another condition. I'll just talk about some variants of Parkinson's disease. Actually, we can go to the slide before, or actually this was the slide. Yeah, this is. So variants of Parkinson's disease are something more than Parkinson's. So we call it Parkinson's plus syndrome. What it means is that besides that basal ganglia degeneration, they have degeneration in other parts of the brain. As a result, they have symptoms of Parkinson's plus something else. So Lewy body dementia, they have in the cortex, so they present more with dementia. And multiple system atrophy is they have degeneration in a lot of different parts of the brain stem, as we call. And then progressive supranuclear palsy is another condition in which the movements, our eyes are impacted. besides the Parkinson's disease, they can't seem to look up and down. So they have a lot of problem coming down the steps because the eye movements are affected. Corticobasal degeneration is another part of the brain which has degeneration, again, can present with dementia along with the Parkinson's. So why is it important to know about Parkinson's plus is because the Parkinson's plus syndrome, they have more symptoms besides the Parkinson's, and also the typical medications we use for Parkinson's, they don't work as well in Parkinson's plus syndrome. So it's a tougher prognosis, I would say. And the next slide is talking about a very common condition called essential tremor. So I think Nalini ji brought about somebody who had tremor. So majority of the patients who come with the tremor think that they have Parkinson's disease. And when they come and we say, no, you don't have Parkinson's disease, but you have essential tremor, it's like, oh my God, what a relief. Because essential tremor is a very common, it's the most common movement disorder. It affects 5 to 10 million adults in the US. Remember, we said it was 1 million for Parkinson's. This is 5 to 10 times more common. And the mean onset of this is younger. So 35 to 45 is when they can have the onset. And this has a very strong hereditary component. So majority of the time they'll say, oh yeah, my mom had it, my dad had it, my uncle had it, my sister has it, my brother who's 10 years older than me has it. So we also call it familial tremor. I wouldn't say 100%, but about 50% people can have a hereditary component in this. And 50 to 90% of the patients, this is just a fun fact, it actually improves with a little bit of alcohol. So you ask them, when you take a drink, does the tremor get better? And they say yes. That tremor is often essential tremor. That doesn't mean that they have alcohol for medication. There are other medications that we use, but it's one of the questions that is asked is, does that tremor get better with the drink? And very often patients, if they're going for a social dinner, they will have a glass of wine before because they know that the tremor will be lesser when they do that. The medications we use are medications we use for blood pressure, propranolol, and some seizure medications, primidone and gabapentin. But it's just important to know that essential tremor is different from Parkinson's, and to be able to differentiate the two is important because that makes a major difference in patients' mindset that they have Parkinson's or they don't. And so now we have some diagnostic tests. We'll talk about how to do that. But the best diagnosis is still a clinical diagnosis. The visit with the doctor, the neurologist, they'll be able to differentiate pretty early on if this is essential tremor or Parkinson's disease.
So having essential tremor a sure way, like does it lead to Parkinson's? No, because this onset is more of this.
So there is a small percentage of essential tremor patients who go to Parkinson's, not a very large. Majority of them do not go into Parkinson's.
Good to know, I think.
Dr. Sharma is, I'm sorry,
Go ahead.
going back to the RLS, restless leg syndrome, is that a part of essential tremor?
No, it's not. Two different conditions. Essential tremor predominantly affects the hands, and restless leg syndrome predominantly affects the legs. And it's a totally different clinical presentation, treatment. So they are two different entities. They are part of movement disorder, but they are different entities.
Thank you very much.
Yes. So these are some of the diagnostics. So somebody who comes for Parkinson's disease, the tests that are ordered is a brain imaging, usually a CAT scan or MRI, usually MRI now. An MRI won't tell if somebody has Parkinson's, but it'll rule out other things like, do they have strokes or other signs, other tumors? So it's a rule out type, but imaging is important. Lab work, the doctors will check, make sure that the chemistries are fine, the thyroid is fine, they don't have anything, any other abnormality in the metabolic system. So a blood test, which is lab work, is important. They'll check other vitamin deficiency, vitamin D is all checked. And then the new testing now is, since 2011, FDA has approved a test called DAT scan. DAT scan is they give a, and we'll talk about it the next, it's a radionuclide which is injected, and then it picks up those cells, the dopamine producing cells pick that up. And a normal appearance is what we see, the comma shape on the left. You see two big commas, that's a normal scan. And that's how we see in the essential tremor. So that area looks normal, the comma shape. But in the Parkinson's syndrome, it becomes smaller. So it doesn't look like the comma shape, but you see the period shaped. So it's like two little circles rather than two large comma shape. So this is how, as now the Medicare is approved, FDA has approved this test called DAT scan. It's a little extensive test. It takes about half a day. It's expensive, but it is covered now. And so sometimes when we want to know it's a little atypical presentation, we do offer this test, recommend this test called DAT scan. And the next slide, we'll go over a little about the treatment now. If anyone had questions about diagnostic tests, we can address it now.
And since it is present, from age 35 onwards, so is it to be periodically included in the test process for 35 and above?
So it's usually a one-time test. Rarely do we need to order it again. It's only to initially see, is this or that? And very often they won't be doing it right in the beginning. Maybe a year or two later, they'll order it to see what it looks like.
Thanks.
So the treatment now is, the commonest treatment you will see is the actual dopamine is given to them as a levodopa, and it's given in a combination with something called carbidopa. And the carbidopa reduces the metabolism in the gut so that more medicine goes into the brain. So we're giving a combination of carbidopa, levodopa, so more levodopa goes inside the brain. The medication in the United States, we call it Sinemet. So that is the commonest treatment. And it was one of the earliest treatment for Parkinson's. These other medications that have come up later are also increasing the dopamine, but they're not dopamine itself. What they're doing is they are reducing the metabolism of the breakdown of the dopamine. So if their breakdown of the dopamine is lesser, then there's more dopamine available. So dopamine agonists, very common, something called pramipexole or Mirapex or Requip is often used early on. So when somebody walks in with early Parkinson's symptoms, the doctors often will start on the dopamine agonist, but not carbidopa, levodopa, Sinemet, because the side effect profile of these medications long-term is better than Sinemet. So dopamine agonists are often started. COMT inhibitors, which is entacapone and tolcapone, are often introduced. And then MAO inhibitors, they are supposed to slow down the progression. So very often they are started. Selegiline and Raziglin are some of the names. We don't need to go over them unless anyone has. And then anticholinergics and amantadine are other medications. So these are the general group of medication. Now for each group, there are some newer medications available, but this is the general. So very often patients are on 3 or 4 different medications. They get started with one, but then the others are added because it's reducing the overall breakdown as well as giving the supplement of the dopamine. And I think we just have 1 or 2 more slides and then we can come back to the questions. So these are some of the newer modalities which are available, which are surgical treatment. It's not, I wouldn't say it's an option only for a few patients which have a medically refractory motor symptoms or have a lot of side effects, so the medications can't be used. So there are 2 types of surgeries. One are what's called ablative, in which they remove a part of the brain cells, which are causing the symptoms. So for example, if somebody has a lot of tremor, then they take away a part of the thalamus, which reduces the tremor, or a part of the globus pallidus, which is causing the bradykinesia and rigidity. And then more common is the newer treatment, which is deep brain stimulation, which is called DBS. In DBS, what you see in the picture, they go in and they put some electrodes in the globe, in that basal ganglion area. Then they take those wires down, and then it comes down, the control comes down on the chest. So what they do is, in this, they don't cut anything, they don't remove anything, but they are kind of giving some electrical impulses, which is increasing or decreasing what's needed for that tremor or the rigidity or for the postural instability. So the advantage of that is that there is no destructive, it's safe, it corrects both bilateral symptoms, it's adjustable. So you could increase it or decrease it. It's like giving a little electrical stimulation or reducing it. The disadvantage is it's expensive and it requires constant ongoing maintenance. So you have to go every couple of months, make sure that it's adjusted right. Is it helping, not helping, increase, decrease? But this is one of the newer treatments called DBS, done by movement disorder neurologists. And we can go to the next slide, and then we can talk about this. So this is an important part, how exercise is so important in Parkinson's disease. So exercise is more than healthy. It's a vital component to maintaining the balance, mobility, and activity of daily living. It eases the non-motor symptoms also. The depression and the constipation is also helped by the exercise. So people with PD who start exercising early in the disease course for a minimum of 2.5 hours a week, which translates to about 30 minutes every day, experienced a slower decline in the quality of life. So their symptoms are slower, and they do better if they're exercising at least 30 minutes every day. And different kinds of exercises, we say mix and match. Tai Chi helps with balance. Yoga helps with the rigidity. Brisk walking really helps. Swimming, biking, dancing, weight training. And there's another treatment called LSVT, which stands for Lee Silverman Voice Therapy, which trains them to speak louder, movements bigger, walking with the largest step. So big and loud is that part of the treatment of LSVT. So these are the exercises really important in the prevention of a lot of different conditions, Parkinson's disease being one of them. And so again, how can you prevent Parkinson's disease? Physical exercise, cognitive exercise, keep yourself mentally active. Social interaction is very important. Staying engaged in whatever you like to do, your hobbies, your social, staying engaged is very important. Good diet, fresh fruits, vegetables, legumes, seeds, nuts. So our good, healthy vegetarian diet is excellent. Adequate sleep. So again, the number, we say 7 to 8 hours, but don't get hooked up on 7 to 8 hours. Just have a nice, refreshing sleep. Usually you say more than 6 hours is great, and a good sleep hygiene. So here I'll just talk about what we mean by sleep hygiene. So sleeping at the same time and waking up at the same time is healthy. Sleeping earlier on rather than too late is more refreshing. Not having electronics in the last 1 hour, all the phone and the TV in the last 1 hour should be stopped. Having no caffeine late in the evening. Exercise earlier, not too late in the evening. Keeping your last 1 hour into relaxing activity is very important. So all of these help in good sleep hygiene.
Dr. Sharma, someone has a question. Do chanting and meditation help?
Yes, so the chanting and meditation are very helpful in keeping your mind quiet in the last 1 hour. So one of the things for insomnia, if somebody can do chanting and meditation in the last hour and a half, is really helpful. And conclusion, whatever we decided to talk, I think we all hopefully got it. We understand the hallmark features, the pathophysiology behind Parkinson's, be able to recognize the early symptoms, and be able to understand the common treatment, preventive modalities for Parkinson's disease. These are some of the resources: Parkinson's Organization, Michael J. Fox Organization, and APDA Parkinson's Organization. Thank you all. Any final questions?
Thank you, Ushaji. Ushaji is clapping and mute, actually. So I'm sure, yes, everyone is. Thank you.
Thank you all. That was great. Great questions. I think we covered really well.